All right. Well, welcome everyone. We're really excited today to be joined by Dr. John Emil Kenny, with Eduardo and myself to talk about venous arterial physiology, particularly how we integrate these for critically ill patients. With HCP rounds, we're interested in hemodynamics, congestion, and perfusion. And really, to achieve optimal perfusion, we have to consider both forward flow, cardiac output, stroke volume, but also the venous physiology. And there's really nobody better than Dr. Kenny himself to talk to us about that. And then normally we have a couple sponsors for HCP rounds. This one happens to be something I'm working on where at Resub we're trying to automate manuscript formatting for different journals. So the idea is that you upload a paper, choose a journal, and then all the formatting that you need for that journal is automatically taken care of. Um, we'd love for you to check it out, and we have a discount on as well. And then finally, normally Flowsonics Medical, of which John is actually the chief medical officer. Normally they sponsor HCP rounds, and we've partnered with them really to put on HCP rounds for the past several episodes. But instead of kind of doing the normal sponsorship pitch here, I thought we'd actually just ask John, like John, when you came up with the idea behind FlowPatch and FlowSonics, what problem were you trying to solve? Can you just tell us a little bit about why you guys created a really cool med tech company, why you're so passionate about solving this problem? And I guess this will also serve as a bit of a disclosure that you are the chief medical officer for FlowSonics as well here.
Yeah, thank you. Thank you so much. So I think the idea for the flow patch was initially it was to just do quick and easy, repeatable dynamic assessments for fluid responsiveness. Um, there's a few papers in the early 2010s that showed that you could use the carotid artery as a surrogate for LV output. So that was kind of the genesis of it. But philosophically, the grounding of it was I grew up in the era of Manny Rivers where the trigger for preload was a low CVP. So basically, measures of low venous filling was the trigger. It was sacrosanct that you gave fluids to a CVP of 8 to 12. And I just saw that philosophy leading to a lot of complications, and then papers sort of started corroborating that. So even though philosophically the origin of the device was to test for fluid responsiveness, it was really more driven by a desire to find fluid unresponsiveness. And
Hmm.
then when we built the device, we started also concurrently measuring jugular venous Doppler, and then that in conjunction with kind of the cross-pollination of ideas through Montreal H&R, Phil et al. Led to some of the jugular stuff that's been interesting as well.
Awesome. Well, yeah, we're excited to hear all about it, and thanks for sharing that. So, Eduardo, maybe I'll ask you a question. Why should we even care about venous physiology, and why do we need to integrate it with arterial physiology?
Yeah, well, that's actually what we're here to talk about. This is, first of all, this is nothing new. I mean, this is the classic Starling curve where we know that higher preload leads to higher cardiac output if you have a normal functioning heart or a normal cardiac reserve. And of course, this comes at a price. The poorer your cardiovascular function, that is either systolic or diastolic, then the higher feeling pressures you're going to need to generate this cardiac output. And thus, this generates four different possibilities that you achieve when you increase preload, right? And then you can increase preload by many ways. This could be a passive rise, this could be fluid challenge, and in sepsis, this could be a vasopressor test. But whenever you increase preload, you pay the price of increasing feeling pressures in order to drive up your cardiac output. And this generates this classic Diamond Forrester profiles, which here are displaying different kinds of Starling curves. For example, the first, I'm not sure if you can see my my mouse here. Is it possible for you guys to see it?
I can't right now, actually.
Well,
Um,
let's just focus on the normal curve, which that's the best case scenario, where you would just fluid load a patient and achieve a great increase in cardiac output without paying so much of a consequence in terms of venous congestion. And of course, the abnormal curve, which is the worst case scenario where you will only harm a patient by increasing your filling pressures without any returns in cardiac output. And of course, many people could discuss whether this is actually the way to treat any patient with sepsis, because we know all of this is going to last for a couple of minutes or maybe less than hours. But even if you have a responsive patient, right in the middle, you can have a patient that does have the beneficial increases in cardiac output, but still paying the price. So you have a setting in which a patient can still be fluid responsive, but now it's already fluid intolerant. And thus we go back to this Diamond-Forrester profile where we have kind of our four quadrants of warm and dry, warm and wet, cold and dry, cold and wet. And I'll let our guests here just kind of dabble more around this four quadrants and why are we now going back to this venous congestion and cardiac output way of thinking about perfusion and congestion and how we assess this at the bedside. Why is this important? Thank you, John Emil Kenny, for being with us. And the microphone's yours.
Thanks. Yeah, I mean, I think you covered it really well. The classic Diamond and Forrester paradigm, I think it's just something that we can all kind of cognitively link to. I distinctly remember in medical school and even in residency, on CCU, it was primarily derived in patients who were post MI with a PA catheter, but you're sort of taught like, is this heart failure that is warm, dry, warm, wet, cold, dry, cold, wet? And it was a way of thinking about cognitively linking filling pressure with output in a way, as it were. And so you're absolutely right. There's nothing particularly new here, but it's the idea of how can we use that framework, which much of us already had gleaned in medical school and in training, and put it to use in linking Doppler ultrasound. So Doppler ultrasound of measures of filling and congestion on the x-axis, akin to the wedge pressure from the Diamond and Forrester paper. And then dichotomizing it, and then doing the same on the y-axis with LVOT-VTI as a stroke volume surrogate, for, in the original Diamond and Forrester paper, it was cardiac index. But I think the nice way of just parsing it into four is that when you're at the bedside, you just need something quick. You can't be thinking about like, unless you're Corbin Haycock, you're not doing, mean systemic filling pressure and arterial elastance and SVR, and you just need something like my brain can hold four things at a time. So like, how can I think about this patient who's in shock in front of me right now, put them into one of these four quadrants, and then think about like the most rational resuscitation approach to these patients. And I think even the somewhat novel aspect of this is that even though it was originally, the framework was derived in post MI, it should work equally well in a patient with septic shock or other kinds of cardiogenic shock, et cetera. So it's just, making it easy at the bedside and conceptually linking venous congestion with forward flow.
And just starting from a really basic level here. So, am I correct in saying that right now all of us are in quadrant one, where we have adequate stroke volume and we're not congested? And if so, what, like in a patient with hypotension in the emergency department or sepsis, what's the relative breakdown between these? Like, are most people in quadrant one? Or like, yeah, what's your sense for how common each of these different quadrants or phenotypes is?
Oh, that's a really good question. It's gonna depend on kind of the underlying pathophysiology, where the patient is, et cetera, et cetera. But you're absolutely right. In theory, we're all sitting here on this call in quadrant one. We all should have, a collapsing IVC and a Vexus of 0, and hopefully we've got an LVO, a normal stroke volume. Breaking this down based on Vexus and LVOT-VTI, I can't really give you specific numbers for that. I don't know if there's been a lot of specific research on that and with this framework in certain patient populations. I can tell you from our concurrent jugular venous Doppler as a surrogate for venous congestion on the x-axis and carotid arterial Doppler surrogates for LVOT-VTI on the y-axis in hypoperfused emergency department patients. Over 50% of them started in quadrant three, which is kind of like what you'd expect if you're hypoperfused in the emergency department, if it's early sepsis or, early volume depletion from other etiologies, you kind of expect to see that phenotype. We have another paper that is soon to be
And
under peer review from another emergency department with a larger patient population, and the numbers tracked out quite similar to what we had already published. Sorry to interrupt.
no, sorry, John. I was going to say, so both of those patients would be patient one and patient two there. They have low stroke volume, their VTI is low, and they don't have any venous congestion. Or if you were using jugular Doppler, they have a normal jugular vein pattern. How can we tell those two patients apart, and why does it matter to distinguish them?
Yeah, I mean, I think, philosophically, the patient two here, who's not showing an adequate augmentation to preload, is this patient that could have this phenotype of what's termed dynamic fluid intolerance, where it's dynamic in that you've got to do a dynamic maneuver to pull it out, and the intolerance is showing that they're having the evolution of venous congestion following that dynamic maneuver. So the dynamic maneuver here is the PLR, the passive leg raise. So in a patient like this, they start off with, the low CVP. So this would be the patient, at when I was, an intern at Bellevue Hospital, putting triple lumens in every MICU patient with severe sepsis and septic shock because that was the biblical response to Manny Rivers. And, this patient could have a CVP of 4 and this patient two, and that would be the patient you just pump with fluids, right? Use CVP, we got to get the CVP to 8, got to get the CVP to 8. And it was just like, we were all seeing these patients just getting pumped with fluids. And it was like, is this really the right thing? And I think what the answer is that, at least in our data set, and I think a couple other papers that we'll briefly touch upon in the next slides, is that in this quadrant three, when you start in this quadrant three, when you're septic, there's probably a 20 to 30-ish% fraction of patients that are already preload unresponsive, even though they've got signs of low filling pressures. So in that patient two, that would be someone like maybe try fluids a little bit. And if you see that they're really starting to get congested and they're not really increasing their stroke volume or cardiac output, then you would switch to vasoactives more quickly than you might in patient one, who is in theory got more of a upright Starling curve, who you give preload to, and they would get more forward flow than they would congestion. In theory, like the perfectly efficient heart would have a slope of 1.0, and you would give that patient fluids, and they would have only an increase in the y-axis and no increase in the x-axis. So it would just be like all forward flow with minimal congestion, and then worsening degrees of cardiac efficiency as defined by the Starling curve.
Interesting. You know what? That totally makes sense. I guess one of the things that I didn't realize, and obviously through collaborating with you, I'm certainly learning now, is how quickly venous congestion can manifest. I always assumed that venous congestion would manifest after hours, or even I think when I started out doing Vexus research, days. But we're saying that with a passive leg raise, within like a minute or two, you can manifest venous congestion during in for patients with dynamic fluid intolerance. How yeah, I'm just like like when did you make that discovery? When were you seeing that? Because I know that you guys were looking at a lot of these preload challenges in real time using jugular Doppler, and jugular Doppler for everyone that isn't as familiar is the JVP and the JVP waveform. Turns out that humans are really bad at actually visualizing the JVP in terms of the actual waveforms and X descent, Y descent. But if you measure the Doppler of it, the physiology that stands true that we all learned in med school is actually very easily visible on the jugular. So my question to you, John, is like when did you make this realization, and how does this impact when you reassess a marker like Vexus or jugular Doppler or even CVP to some extent after a fluid challenge?
Yeah, I mean, starting to see it pretty commonly, like in the 3 times out of 10 early septic patient kind of fraction. So, we've published a couple years ago, we published an N of two where we sort of described this physiology in particular. When we actually have the video of this evolving of this dynamic fluid intolerance, where we had a patient who, the patient was wearing our device, and the physicians were blinded to the output of the passive leg raise from our device, and so the physicians just resuscitated the patients as they would without knowing the results of our device. And so this patient had a passive leg raise. Patient was fluid naive, had sepsis, had a collapsing jugular vein, continuous low preload jugular vein. We did a passive leg raise, and he just got congested on the jugular. Like it went out to, S equal to D, kind of pulsatile physiology on the jugular, and the carotid metrics actually fell. So this patient had this early sepsis flat Starling curve physiology, and the patient went on to get, over 3 liters of crystalloid because the clinicians were blind to the device. And the patient ended up obviously in the ICU on Levophed. And the next day, the echocardiogram showed that the patient had a blown right ventricle, presumably from sepsis. There was no pulmonary embolus or anything like that.
Fascinating, fascinating. And I was just pulling up some of the data we have locally. We haven't published this yet, but we did a study looking at venous congestion, septic shock, and we also had echoes with VTIs on these patients. And we found that about 10% of the patients in early septic shock were actually in quadrant four. So that's congested with low stroke volume, and about 10 to 15% were in quadrant two with congestion but adequate stroke volume. And so, and you know what, there's big wide confidence intervals on this. This is something that we need to study more. And actually, we are studying, Eduardo and I, with Andromedavexis and many of the other people even on this call. Um, I think that increasingly we're recognizing that this isn't just a late phenomenon from over resuscitation, but is probably one of the early presenting phenotypes of septic shock, where patients will have either cardiomyopathy or simply which could be chronic cardiomyopathy or acute, and manifest congestion that's causing organ dysfunction as part of their pathophysiology of septic shock. So super interesting.
Yeah. Yeah, well, thanks for that, Russ. I think that's exactly what we're seeing in Andromeda because we are getting patients right at enrollment, and so some of them actually, some centers we've moved away from heavy fluid resuscitation from the get-go, and we're still seeing a fair number of congested patients. Probably most of them with a little bit of a heart failure with preserved ejection fraction that just diastolic function worsens during the septic process, and then any amount of fluid resuscitation will, even if it's small, will lead to some kind of venous congestion.
It,
So, yep.
Eduardo, I was just hoping you could elaborate upon that because that is kind of a common, like the septic diastolic dysfunction, or maybe it's underlying chronic diastolic dysfunction. It's kind of a common um, response that we'll see in the field to giving fluids, where we'll have a POCUS user who doesn't necessarily do full diastology, but will say, oh, the ejection fraction looks 60%, like they could use fluids as do you have thoughts on that, on like how the interaction between diastolic dysfunction and sepsis and congestion could evolve with resuscitation?
Yeah, well, measuring diastolic dysfunction using ultrasound is, first of all, has never been validated in your hyperdynamic circulation patients. And so what I think is now we're seeing a surrogate of this diastolic dysfunction causing backflow from the right atrium, which is an early marker, especially in your more sensitive veins, such as the intrarenal Doppler, which is usually the one that gets affected at the earliest. For sure, when we started this journey, I thought we were going to see very little congestion at the level of the kidneys. And then I even started thinking, well, maybe this is just false because we're seeing many congested kidneys with normal portal vein and then just mildly increased intrarenal Doppler. But as we've seen more and more literature from the cardiac world, we've seen that, for example, in patients with heart failure, they can have a normal IVC, a normal portal vein, and already they can start having a pulsatile or biphasic intrarenal Doppler, and that's associated with bad outcomes. And then there was a recent paper by Noriko Ida, he's the echocardiographer who came up with intrarenal Doppler in the first place. And he studied patients with sepsis, not heart failure patients, and he saw a fair number of them develop altered intrarenal flow with little fluid resuscitation. I think it was an average 1.5 liters of fluid resuscitations in the ED, and that was not associated with changes in CBP. So this is an early marker, but it was associated with the amount of fluid received and, of course, outcomes such as acute kidney injury. So I think it could be a real marker of a difficult problem to diagnose, which is diastolic dysfunction. And now, of course, diastolic dysfunction of the right ventricle, well, then again, is additionally harder to diagnose.
I love that. And one of the ways that I conceptualize that is we're all familiar with the idea that for a patient with left-sided heart failure, they might walk around chronically with an EF of 20%, but if they're well decongested and they have excellent kind of volume management, they will not have any pulmonary edema. Or even a patient with severe diastolic dysfunction, they might have a normal EF but severe diastolic dysfunction but no pulmonary edema. But when they become acutely unwell, when they receive fluid resuscitation, very quickly they go into flash pulmonary edema on the left because of their diastolic dysfunction and the interplay between their acute illness and their fluids. I think in my mind, venous congestion is the same thing on the right. You have a patient who has a propensity for congestion due to either acute or chronic diastolic dysfunction, who now, under the right loading conditions, manifests that as organ level congestion. So that makes total sense from what I think as well there.
Sure, and I think that can bring us to our next topic, which is the same one. It's very related, but I think it's a very interesting one to go a little bit more deep into, and that's from this paper. It's a beautiful paper by our friends in Chile, Eduardo Catan and Glenn Hernandez. They just did this fantastic study on patients who were critically ill, and they were looking for signs of fluid responsiveness and the coexistence of venous congestion signals. And what they found is that there's a great amount of patients who are both fluid responsive but already have venous congestion signals, and that could be altered lung ultrasound or altered here you altered E over E prime ratio, altered CVP, or altered VEX score. And something I found very interesting from this paper is that patients that were fluid responsive were at greater risk of acute kidney injury. And if you only take that piece of information, you'd say, okay, we need to fluid resuscitate them a little bit more. But then you go and do the complete analysis, and you find that even if you're fluid responsive, if you have any signal of venous congestion, you've actually have a way larger risk of acute kidney injury than only being fluid responsive. So I think, to me, that tells me that we have kind of a conundrum as to we think we need to increase forward flow in the septic patients with AKI, but at the same time, we're seeing some congestion signals. And if we only do what's standard of care, which is a passive leg rise and measure cardiac output, we might think, oh, the solution is fluids. Then I think we're forgetting about these fluid intolerance signals, and we might end up doing harm. So our question for you, Janamil, is how do you navigate the risks of fluid resuscitation in a patient who might already have signs of fluid intolerance? How do you balance the risk-benefit ratio of worsening congestion, but trying to achieve greater cardiac output?
Yeah, I mean it's the $64 million, $64,000 question. I think this really just sort of distills down to that tension between guideline based care and physiology based or personalized resuscitation. And I think that this is really where, the art of of hemodynamics comes in rather than just pure science. Or maybe it is pure science, but it's one of those things where it's always going to be the hand waving cop out answer of, it depends on the patient in front of you. Like if eh, balancing the risks and benefits of additional preload, which will tend to congest the patient versus, how much juice are you going to be able to squeeze out of the forward flow. I think if you use a measure that's more continuous on the x-axis, so portal vein pulsatility fraction or renal venous stasis index, in the jugular vein, we've got these categorical variables of worsening congestion, but kind of the more fine-tuned, or even just an absolute CVP to some extent, the more fine-tuned you can be on the x-axis, kind of the closer you can see you are to getting to that warning point. And if the patient's starting to get, you know, systemic venous congestion, they've also got pulmonary vein congestion, they've also got some, evolving B lines on lung ultrasound, then I think that, the risks of fluids are much greater than the benefit. And then, the goal is to get the patient to quadrant one. So then you're thinking, well, how do I get the patient to quadrant one? Do I need a little bit of an inotrope? Maybe I actually need to pull some fluids off to improve cardiac efficiency if there's valvulopathies, or if, there's signs of excessive preload in the heart, embarrassing cardiac function. So it's kind of one of those things where there's not a straightforward answer. It depends on the patient in front of you, the overall risk of fluids, and the benefit of fluids. But at least using Doppler ultrasound to gauge the venous congestion and the forward flow concurrently will at least help you think about the right direction to go. Yeah. Does that make sense, or is that a cop out?
No, it definitely makes sense. It's not a cop out at all because this is such an incredibly complex topic to give a definitive like yes or no answer, and that's kind of one of the reasons why we have HCP rounds is to discuss the fact that physiology does not have a binary answer, and you have to understand the complexity of this really complex system. I just wanted to add that one more way that this influences my management is if I have a patient who's fluid responsive, yet they have features of fluid tolerance, they might be a patient that I would consider to try to use a vasopressor to recruit to increase your filling pressures to simulate fluid responsiveness. Because really, fluid responsiveness, we're saying that there's low preload or low mean systemic filling pressure. So you can increase your mean systemic filling pressure by giving somebody fluids. Or you could increase your mean systemic filling pressure by giving somebody a vasopressor and increasing the squeeze on the venous side. So if they already have features of congestion, I'm more likely to trial a vasopressor to recruit that mean systemic filling pressure and venous volume instead of fluids. But I don't know, Eduardo, John, do you guys think of it similarly?
So just to rephrase that, you're saying, say, if a patient starts in quadrant three, you might do, norepi or something to try and ostensibly push them to quadrant one, not through external preload, but sort of through an internal venous preload from alpha, let's say.
Exactly. So yeah, exactly that.
Yeah, I mean, as long as you're doing reassessments, I think that's the important thing. Like if you start them on norepi and they go, in theory, like the patient could still have a patient two response here from norepi, or a patient one response from norepi. So I think that that's rational, just so long as you're doing, continued Doppler reassessments.
Have you seen many patients when you put them on norepinephrine develop congestion from the increased venous tone? I haven't, and I wonder whether some of that is that even with norepi you get a bit of beta effect. So the small amount of inotropy improves the cardiac function and actually helps mitigate the congestion that you would see otherwise. But I'm curious, Eduardo, John, have either of you seen that?
I would
I'll
speak
let,
for myself. I think I have.
yeah.
Though, you know, we've used both norepinephrine and vasopressin. I'm never sure whether this was the vasopressin. Um, I think it's very possible that we see this in patients who have some cardiac dysfunction and they won't tolerate the increasing afterload that's created by the norepinephrine. And then, of course, diastolic dysfunction sometimes might worsen with tachycardia. And in these patients, it's not, it wouldn't be unreasonable for them to develop worsened congestion that they get a benefit from. I've seen a definite changes in IVC and intrarenal Doppler after vasopressors. Not so much portal vein, though.
Yeah, it's interesting that you mentioned that. The one case that I've seen, at least with our device, that really comes to mind was a patient getting norepi and vaso. And to your point exactly, I think the potentially the combination of the two just afterloaded the LV too much. And so you have to sort of think of these Starling curves as it's I think a common misconception of the slope of these Starling curves is that it's entirely determined by inotropic state, but it's a dumb curve. It's just telling you what output you're getting for what input. And so a very high afterload will also shift the curve down and to the right. So if you just purely afterload the LV, you'll get a lower stroke volume at a higher filling pressure, which defines a diminished slope. And so I think in some situations, which ones it's tough to define, but because norepi in particular is, as we all know, it's more alpha than beta, you could afterload. Corbin would do arterial elastance and calculate all that stuff out to see if the VA coupling is being impaired because of a higher arterial elastance. But in theory, if you shot the EA way up relative to the EES, the end systolic elastance, then it's too much afterload, and this curve would shift down and to the right, and you could get more of like a quadrant 3 to 4 progression rather than a quadrant 3 to 1 progression. So I think it's perfectly rational just as long as you're doing the reassessment.
Yeah, well, I'd like to move forward because we have a relatively recent publication that kind of tested this idea of the Diamond Forster quadrants evaluated by Venous Doppler. They actually did an assessment of VTI and portal vein pulsatility index or pulsatility fraction, as I would call it, in the population of patients where you're expected to have some altered cardiac function. This is cardiac surgery patients. And this is a fantastic study, I think, and we should talk about it. What they did was they took 40 patients undergoing cardiac surgery, and then they did passive leg rise and measured the changes in VTI and the changes in portal vein pulsatility fraction. For start, they were all fluid tolerant and all fluid responsive during the passive leg rise. And then what they did they gave a fluid challenge around a 500 ml bolus of saline, and they measured the changes in VTI and portal vein pulsatility fraction. What's very interesting is they found that 50% of patients within 2 minutes of fluid administration, they already had a greater than 50% portal vein pulsatility fraction. And this was not something, I'd say this was not noise, given that these patients, when you looked at these patients that developed venous congestion so rapidly, they had a specific phenotype, which was a worsened RV function, and also they were more likely to develop acute kidney injury. So I think these were in fact patients with a different, of course, a different RV function that cannot tolerate this fluid challenge, despite all of them having an increase, or most of them having an increase in actually all of them, because a inclusion criteria was for them to be fluid responsive. So all of them responded, 100% responded, but 50% got congested with the fluid challenge. And then all of this that were congested had poorer RV function and had greater incidence of acute kidney injury and even severe acute kidney injury. So that I think that kind of answers some of the questions we have, whether we can actually diagnose these conditions at the bedside. Is it that fast? And I think 2 minutes is pretty fast. And I'm not sure how this translates to sepsis, given these patients are obviously a different set of patients, which are prone to have cardiac dysfunction. But I think this is a fascinating study that answers some of the questions, wouldn't you think?
Is that for me?
Yeah, sure, or Rose.
I'll let Ross take it.
I mean, I don't really have too much to add to that. I totally agree. I think this just shows that the fluid tolerance perspective and the congestion is equally as important, if not in some ways more important than the fluid responsiveness when they coexist, and that this is something we need to be assessing kind of dynamically. I guess I think the challenging part for me in clinical practice is, although if you're just doing portal vein pulsatility, it's not that complicated, but there is kind of a time component to this where you're at the bedside for the entire kind of maneuver here. Thinking about kind of scalable ways, like I guess, John, what would you see as the most repeatable way to do this at the bedside, and not just kind of plugging your own jugular Doppler and flow patch, but are there other kind of more scalable techniques that you could think to this so that any clinician in a busy emergency department, OR or ICU can use this?
Yeah, shameless self-promotion. I mean, obviously that I think that's the elegance of the device of the flow patch is that it gives you just continuous measures of non-invasively of you know venous and arterial flow. So there's obviously there's non-invasive solutions to this that are much more convenient than going and getting the probe and doing these measurements every 5 to 10 minutes. Um, but like it also like to some extent you could rely on a central line like our if you do a leg raise, does the CVP go from 5, and again like all of the caveats that come along with measuring the CVP is that you're going to do a leg raise with the CVP, it's got to be leveled and taken at end expiration, so like you can sort of say that it would make sense in theory, but in practice it's like it's next to impossible. So maybe I'm talking myself out of this, but the idea of being able to measure real time concurrent changes that are reliable, accurate, in on the venous side of the circulation. The closest thing that we have to that would be, continuous wedge pressure or continuous CVP. And there's just so many caveats there when you're trying to do a dynamic maneuver that makes it really challenging. And then measuring real-time changes, like if you had a Pico in place, which, and as far as I know, no one in North America does, but it's more of a European thing where you can get real-time changes in stroke volume or cardiac output. That's going to be sort of the best case scenario for measuring real-time changes in arterial flow. Short of that, it's challenging. It's just a challenging thing to do, which is kind of like why easy ways to repeat that are I hope the future of critical care medicine.
Absolutely. Now, one thing that Glenn Hernandez spoke about when we had him on a few months ago was that there's an idea of like kind of hemodynamic coherence where we make changes in the circulation, like either on the venous or arterial side, with the hope that we improve end organ perfusion. And that early on in resuscitation, particularly early on in septic shock or hemorrhagic shock, when we make a change to the macrohemodynamics, we give somebody fluids or vasopressors or an inotrope, they improve their organ perfusion. And we can tell this by the cap refill time, which is a good surrogate for organ perfusion. But that later on in disease courses, patients become hemodynamically incoherent, where changes to the macrocirculation aren't translated to the microcirculation. And one way that's been proposed to assess this is doing a passive leg raise with a reassessment of cap refill time pre and post. Because the preload challenge that you get during the cap refill, you can then see in a hemodynamically coherent patient the impact of that on fluid responsiveness, but also congestion, because if you did a passive leg raise, you would potentially manifest venous congestion as well. And so my question is, when we're trying to weigh a patient that's both fluid responsive but also dynamically fluid intolerant, do you think using cap refill time during the passive leg raise as another adjunct has value there? And could that be kind of the like tiebreaker between whether or not the increase in cardiac output from the fluids that from the fluid responsiveness offsets the risk from the venous congestion? I'm just curious on both of your thoughts with that.
It's such a good question, and I don't want to, Glenn Hernandez is obviously, a world expert in this space. And so I would certainly defer to his opinion. I think one of the concerns that I generally have between the macro and the micro, or coherence, incoherence, is the idea of like what's normal in health. I don't know if it's well defined.
Mm.
There's been a smattering of investigations, but what we're always taught is that in health that all organ systems more or less have an autoregulatory curve, and so like particular tissue beds are trying to maintain a constant flow, and we think of it for intracerebral blood flow. But in theory, kind of all organ beds have their own autoregulatory curves, and there's this sort of space where augmenting perfusion pressure to a tissue bed actually doesn't increase flow because um, there's autoregulatory changes in the precapillary arterioles that maintain a constant flow. So I'm of the maybe perhaps naive impression that in health there kind of should be a dissociation between macro and micro, because if you increase flow macro, a functioning tissue bed should see that increase in flow and then suddenly retard that flow because it's got a normal autoregulatory curve. Whereas in diseases like sepsis, you lose that autoregulation, and then there becomes more of a direct relationship between the macro and micro because the precapillary sphincters are dysfunctional. So I don't really know what to make of that because like if if you do a passive leg raise in 100 healthy volunteers, what does the cap refill do? I don't know. Like presumably it would be constant, but
Yeah,
I'm
and
not sure
sorry,
what to
just
say.
just to just to pop in there to clarify that a bit. So with hemodynamic coherence, we're talking about hypoperfused patients in all contexts. So I agree. In a normal person, you shouldn't see an impact on your kind of cap refill time because if you're normal, you're not going to get super normal from increasing your cardiac output because of exactly the exact mechanisms that you allude to. But in a patient with hypoperfusion, early on in their septic course, they often have more hemodynamic coherence, which means that if you improve their stroke volume, if their stroke volume is low, or their MAP, if their MAP is inadequate, that will translate to a normalization, not a super normalization of their cap refill time, but just a normalization. Versus later on in the disease course, you may not see that the coherence, and you might be able to return their SWAN numbers to being totally normal, yet their microcirculation is still very dysfunctional for a variety of mechanisms. I don't know if that helps clarify that a little bit.
Yeah, I mean, I mean, it makes sense. It's just like, when you have in sepsis, when you just have differential vascular beds responding differently to the disease process and differentially to whatever vasoactives the patient's on, alpha tone versus, less alpha tone, it just makes, I think it makes those macro micro associations a little bit more challenging
Totally.
to make.
No, that
I
that makes sense.
But I'd love
yeah.
to know Eduardo's thoughts here.
Well, no, I'd like to add that, not only do are we now being able to assess, your difference in cap refill and your difference in VTI with passive leg rise, but I'm going to return to this concept of dynamic fluid intolerance because in this recent paper, not only did they see the increase in portal vein pulsatility fraction with fluid challenge, but also with passive leg rise. And the area under the curve for predicting one with the other, that is, if you do passive leg rise and the portal vein pulsatility increases, it was 0.94 to predict that when you're going to give fluid, the same thing's going to happen. And I think that's a very relevant test not only because it informs us of the risks of fluid loading on organ congestion, but also I'm not sure your experience, but my experience during VTI during a passive leg rise is way less reproducible than any of us would like. And I don't think portal vein is that hard to do, even when with changes in position. I think that opens up a new possibilities of rather than whether I care or not if VTI is going to improve or the cardiac output is going to improve, then I do care if portal vein pulsatility is going to get worse. And this paper showed that these patients are at higher risk of organ injury, uh, especially acute kidney injury, which is a congestive type of kidney injury. Given that these patients were not septic and had no other factors causing AKI, we can be pretty certain one of the principal determinants of AKI in this population was, in fact, venous congestion. I think that's something very relevant to keep in mind, that we can now do a dynamic fluid intolerance test, and there's a little bit more literature backing that up, and I think that's a concept you came up with, Jeremy. But it's certainly beautiful to see it published.
Yeah, I mean, I share all of those sentiments. When I first came across this paper, I was very excited to read it, and I was really excited to see, a group delving into more of the nuances in physiology here, looking at the crosstalk between venous congestion and fluid responsiveness during a passive leg raise. So in the next slide, everything that you mentioned, 100% agree with. This is kind of like the Doppler Starling curve that they published, as it were, with, instead of VEXUS or CBP or venous Doppler on the x-axis, they've used a continuous variable, the portal vein pulsatility index. So for those of you on the call, like a normal portal vein pulsatility index is kind of close to zero. It's generally very continuous, non-pulsatile, and then as you get increasingly severe congestion, it becomes much more pulsatile. So um, zero is essentially normal, and above 30% as you approach, above 50, it's abnormal. In this paper, 50% was kind of considered the dichotomy for low from abnormally high, and then they plotted that with the VTI on the y-axis. So this is really kind of a cool recapitulation of that Diamond and Forrester framework that we talked about on the first slide.
Yeah, just one more thing. This curve is fantastic because it's making a distinction between those patients who developed a high portal vein pulsatility index after the fluid challenge and those who did not. And the slope is exactly the same. So that means this is probably not mediated by systolic functional differences, because the slope would be different. Then for the same increase in portal vein pulsatility, you get the same increase in cardiac output or in VTI. However, the curves are shifted, the intercept is different. So that to me suggests it's a diastolic problem. I think that goes back to the difficulty in assessing the diastolic dysfunction that's present in some patients, and maybe venous Doppler is one window into this altered feeling patterns associated with the difference in the congestion needed to achieve a high cardiac output, and thus it gives greater significance to assessing this dynamic fluid intolerance test, I think.
Yeah, thank you for making that distinction. So the blue line and the blue dots are the patients that went on to develop venous congestion following the crystalloid challenge. So it's kind of dichotomized here. Whereas the gray dots and the gray line are the patients who did not go on to develop venous congestion following the crystalloid challenge. So yeah, and then everything that you mentioned is exactly correct.
And so I guess just as we're heading into the last couple minutes here, what's next for integrating arterial venous physiology? We have frameworks now. We have Starling curves. We have the terminology, dynamic fluid intolerance. We can assess it in different ways. What do you think's needed to get this to the bedside, John? Is it more research? Is it just more adoption of it? Is it more webinars or more tweets talking about it so that people are more familiar with it? What are the barriers to actually implementing this at the bedside, as you see it, as somebody who lives and breathes this on a daily basis for the most part?
Yeah, I think it's just the foundation is just a common language, where we can think about these two. You might think of them as opposing frameworks, and I think that was kind of the genesis of the idea of making the Diamond and Forrester relationship or the Doppler Starling curve is you'd have kind of a group of people publishing only on venous congestion and venous signals, and then you had a group of people publishing only on, delta stroke volume, delta cardiac index, fluid responsiveness. It's like, how do we link the two? And, we should realize that they're going to coexist. We're going to see, you know, decongested patients who are fluid unresponsive, and we're going to see congested patients who are fluid responsive. But we need to be able to kind of think about why. And, at least at a minimum, the Doppler-Starling framework integrates the two. So one of the things that I was kind of, or I talked about, I'd like to see just future elaboration of the different quadrants, especially in larger um, populations, larger sample sizes. Like, like what's Andromeda shock going to show if we could, put patients into um, the warm, wet, warm, dry, cold, wet framework, and how responsive or unresponsive those patients are, and what their outcomes are. Is there a worsening outcome for patients that start sepsis in quadrant 4? I mean, it would make sense if you're kind of in that cardiogenic phenotype, then a patient may be in quadrant 3. But it would at least help kind of using a Doppler fingerprint or a Doppler phenotype to help drive how we think and manage these patients.
Awesome. That's incredible. Well, thanks again for joining us, John. Appreciate your time. And yeah, I've learned a ton, and as always, and thanks for everyone for joining live. We'll post this on YouTube in a couple of weeks if for anyone who missed it. But thanks again for coming on.